Hey everybody, it's Dr. Wood, and today we're talking about Chapter 23, which is going to be our musculoskeletal disorders. And so this is a common reason why patients are going to show up to clinics and ERs and things like that. Mainly, a lot of symptoms are going to develop include joint stiffness and pain and inflammation, and sometimes related to that they can't see weight loss, but imagine if you have someone who has chronic musculoskeletal issues, they're sitting around on the couch all day long. Weight gain can be another common thing as well that can actually further exacerbate some of those conditions, as we'll see in just a little bit. But certainly with things like osteoporosis, you can see deformation of the bones, you can see fatigue and weakness and all kinds of terrible things that happen in these patients. Overall, though, what you're going to find is this loss of motion and immobility, and this can help to decrease their ability to complete their activities of daily living or their ADLs. If they can't go to work, if they can't get around, oftentimes this is a big reason for a lot of chronic opioid use, a reason why patients lose their jobs, related to a lot of these musculoskeletal issues here. So a big problem in the U.S. here. First off, let's look at osteoporosis and some medications for that. Basically, osteoporosis is something that occurs later on in life, and you typically think about this in postmenopausal women. Basically, after menopause, women lose the ability to produce a lot of estrogen, and normally estrogen has good positive effects on the bone to help strengthen it and keep it nice and strong. What happens, though, with osteoporosis, they end up losing bone mass, becomes much more porous and brittle, and thus fractures are very common. You see vertebral fractures and femur fractures and all kinds of things like that. This is a big reason why patients lose a lot of function as they get older, is because they have a fracture secondary to osteoporosis, and that can lead to a lot of disability, a lot of mortality in some cases there. So this is an issue here, right? Now, reasons why this develops include, as I mentioned, lack of estrogen. Just with typical age, you're going to see this as well, and some of it may be related to disuse or dietary factors, right? So for healthy bones, you need decent amounts of calcium and vitamin D. Basically, vitamin D is going to really be effective for helping us to regulate how we're processing calcium, and calcium is what gets put into the bones that makes them so strong in the first place. So we have lots of different drugs that can help us out with this. Probably the most common things you're going to find here include the bisphosphonate drugs here. These are kind of the main ones we're going to start most patients off on after we get them started on calcium and vitamin D. Basically what this is going to do is it helps to prevent the cells that take up bone. It actually helps to prevent them from working as well, such that we can lay down more calcium, lay down the bone more strongly, more soundly. And so most patients are going to at least be started out on one of these drugs here. We also have some that are available via IV, which is nice. You can see here some patients may only get it every 3 months. Sometimes patients will get it once a year, depending on the drug there. So these are kind of your go-to drugs, right? There's some other ones you can use as backup, including some calcium preparations. We'll talk about these a little bit later on, but essentially these bisphosphonates are the main one. Sometimes for patients who, for instance, may have issues of history of breast cancer and things like that, we can use a selective estrogen receptor modulator like raloxifene. It's going to be used occasionally as well. So a lot of it tends to be on a situation by situation basis here, but the bisphosphonates are the most common, along with vitamin D and calcium. Now, osteoarthritis is going to be a very common thing for patients to complain about coming in, especially as time goes on and they're getting older. You can see here that pain and swelling is quite common, and eventually you're going to see damages done to the actual bone once that synovial lining is kind of degraded down. Basically, it's a lot of mechanical pain being developed because of bone rubbing on bone, and that can eventually lead to actual bony changes as well as time goes on. In contrast to that, you have things like rheumatoid arthritis, and so whereas osteoarthritis is a use and wear and tear kind of disease, rheumatoid arthritis is an autoimmune disease where basically your body is attacking itself, such where you can see a nice healthy joint. Eventually you're going to find inflammation and degradation of the tissue here to where it gets all large and deformed, and basically you're going to see a lot of pain, stiffness associated with that, and overall loss of function, especially if it's affecting places like the hands and affecting the joints there, can be a big issue. So the medications we're going to use for these patients for osteoarthritis, you're going to more focus on using your NSAIDs and your glucocorticosteroids. The DMARDs are going to be used in conjunction with the other two categories for rheumatoid arthritis, which makes sense because DMARD stands for disease-modifying anti-rheumatic drug. So the NSAIDs, we know about them a little bit already as antipyretic agents here, but they provide a big amount of relief by decreasing inflammation, but they don't really do anything to help prevent the disease from progressing on. That's where our DMARDs are going to be coming into play there a little bit later. We'll find that overall the NSAIDs get broken down into your salicylates, which includes aspirin, and then your non-salicylate. This is like your naproxen and ibuprofen, things like that we've talked about previously. Remember that the NSAIDs can cause gastric irritation and bleeding, and is the leading cause for peptic ulcer disease here in the U.S., right? Now, while aspirin may be the least expensive, it tends to be more associated with GI distress, and so we don't recommend taking this over the long run. Thus, you're going to find that we use our long-acting NSAIDs a little bit more frequently. Again, as I mentioned, aspirin can be administered with an enteric coating. Sometimes that can help out a little bit in terms of effects on the stomach. But again, typically don't recommend this often for chronic management of osteoarthritis, rheumatoid arthritis. However, looking at your non-salicylates here, you can see there's a huge number of different medications. We've mainly talked about ibuprofen and naproxen before because these are available over the counter, but there are plenty of other agents that are available with a prescription. Some benefits here include longer durations of action, where maybe you only have to give the drug maybe one time a day, like nabumetone. Some of them come in different formulations. So, for instance, diclofenac comes as a gel, to where if maybe only the left knee was affecting the patient with osteoarthritis, you could just apply it just there. That helps to limit some of the systemic side effects you might see due to the effects of these NSAIDs. Other drugs you can use potentially include COX-2 inhibitors. Basically, this is good for patients who have a history of GI disease related to NSAID use. This actually helps to limit some of the degradation of that stomach barrier there, and basically is a little bit safer for those patients. The only drug in this category we use nowadays is called celecoxib or Celebrex. And again, much safer on the stomach, so it's good for if you have a patient with a history of peptic ulcer disease. Celebrex is going to be the one to go with. Now, the glucocorticoids can also be used to help reduce inflammation. We can either use these orally to kind of work from a systemic standpoint to help decrease inflammation, or you can actually use intra-articular injections, where you actually inject things like triamcinolone into the joint itself to decrease that inflammation. So good for short-term use if you're having a patient with a big flare-up, but you don't like to use it long-term because a lot of the side effects we've talked about before. And remember, typical ones include things like prednisone and dexamethasone. Now, with your DMARDs, or disease-modifying anti-rheumatic drugs, there's a lot of different ones that fit into this category here. But basically, these are good because they can slow down the progression of things like rheumatoid arthritis, right? You wouldn't use something like methotrexate for osteoarthritis because the pathophysiology is just different, right? With osteoarthritis, just wear and tear. You can't really do anything about that, whereas methotrexate can slow down the inflammation and hopefully prevent the joint from getting any worse, right? Azathioprine would be another example of that. What's interesting, we actually used to use gold salts to treat rheumatoid arthritis, things like Solganol and Rydara. We don't really use these anymore because they tend to be quite toxic, and we have a lot better agents that we can use nowadays for this. But it's interesting, different metals have been used in the past for different therapeutic purposes. Other drugs you can use include things like hydroxychloroquine, penicillamine, etc. And interestingly enough, you can actually try, especially for osteoarthritis, replace basically the synovial lining that they're missing by giving replacements, things like Synvisc and hyaluronate or Hyalgan. This can basically try to replace the synovial lining they're missing and try to help make it so that there's more lubrication between the joints and such you don't get that same bone-on-bone kind of injury there. Now, gout is another common joint issue that patients are going to complain of, and I love this picture here that someone was trying to describe what gout felt like, and this is the picture they used to describe it. So you can imagine quite how painful that looks when that little devil there is biting you. Essentially, gout, though, is a disease state of hyperuricemia, where uric acid, which can come about from degradation of things like proteins and DNA, and basically patients will have hyperuricemia, high uric acid levels in the blood, and eventually that can actually crystallize out. So based on the level of the uric acid and the pH and things like that, they can crystallize out. And you typically see the great joint or the great toe being affected, kind of most typically is what you think about. But other places can be affected as well. Things like the ankle, the knee, the elbow, really any joint can be affected there. And essentially, a couple of different things we can do there. For one, you can acutely try to end the attack which can include things like NSAIDs, which we've mentioned before, and drugs like colchicine or Colchris can be used to try to decrease that inflammation immediately in the joint. And then we can give drugs to try to prevent reoccurrence. So here's one called allopurinol or Xyloprim. We actually give this to patients, and it prevents them from producing uric acid in the first place. So if they can't produce the uric acid, there's nothing to precipitate out into the joint. So that can be another way to prevent patients from developing this overall. And looking at the muscle, so there's a lot of pain, a lot of issues that come about from patients who have muscle spasms and spasticity. And essentially what that means is we're having involuntary contractions of the muscle that are basically causing severe pain, especially if it occurs around an injury, things like that. And so you're going to find that skeletal muscle injuries tend to be self-limiting, whereas issues of spasticity tend to be more coming from a neurologic standpoint. And so these can be more chronic, more difficult to manage. And so there's several different categories here we can use, including things like skeletal muscle relaxants. This includes drugs like your baclofen, tizanidine, carisoprodol, things like that. And overall, they're working from the brain to basically try to decrease activation of those muscles. And so the problem though is that because they don't work just on the muscles, but they work in the brain, typically see a lot of sedation associated with these. So patients shouldn't be operating machinery. They shouldn't be going to school because they're not going to remember a whole lot because they're going to be so groggy from the medications here. These are things you want to certainly consider when administering these drugs to your patients there, right? Let them know that, hey, this is something you're going to see with it, that it may take a few days before you get used to it. And because of that, if you're taking it for a long time, you can actually develop physical dependence where you're so used to having that drug around that if you start to come off of it, your body's going to go into withdrawals essentially and say, hey, wait a second, we want that drug back. That's what we're used to. And so that's one thing you'd want to taper them off the drug over several weeks to months potentially. Again, here's some examples. I mentioned some of the more common ones you run into, things like baclofen, cyclobenzaprine. They basically all work essentially the same. They may have slightly different mechanisms, but ultimately the side effects are all the same. They're basically the sedation, cloudiness in the mind, memory impairment potentially. Those are all things we're going to see most frequently. There's another interesting musculoskeletal sort of issue here that can develop called myasthenia gravis, where basically it's a progressive disease that causes muscle weakness. If you can notice here, this the right eye of this patient tends to be drooping more so than the left eye, and that's something called ptosis, Ptosis, and essentially is related to the loss of acetylcholine receptors. We know acetylcholine is really important for our skeletal muscle to cause activation and to contract. Basically, by losing those, you end up seeing this weakness that can develop, and it can affect other muscles in the face, but usually this drooping eye is typically one of the most common things you think about. And so one of the ways we can actually treat this is by trying to increase the concentration of acetylcholine, which we can do with drugs like pyridostigmine or mestinon. Basically, you go ahead and give this drug, and it will help to prevent the breakdown of acetylcholine, such you have higher levels, and that way you have more of those receptors being activated, and then you'll get strengthening of the muscles here that work a little bit better. But this is a lifelong treatment. It's going to be something that your drugs get less effective as time goes on, and so it can be pretty problematic for the patients in the long run. Now, finally, fibromyalgia is a type of neuropathic pain that can occur in many patients. It's a chronic pain issue for these patients that can lead to things like stiffness and disturbed sleep and depression, all kinds of things. You can try NSAIDs for this, but because this is not really going to be an inflammatory sort of condition, it's more neurologic in nature. We need to focus on treating the neurons, and so this is where things like our anti-seizure medications or antidepressant medications can have really good effect here. So this is where we use things like amitriptyline, duloxetine, which are antidepressant drugs, or gabapentin and pregabalin, which are anti-epileptic medications or anti-seizure drugs. They can be used here and basically see improvements in the neuropathic pain these patients are experiencing who have fibromyalgia. So that's it for this section. If you have any questions, please let me know, and I'll talk to you soon. Thanks a lot. Bye.